Welcome everybody. My name is Ajay Kiratne and I'm here from Columbia University and in New York. And it's my pleasure to introduce two great colleagues and hopefully have a very exciting webinar today where we'll talk a little bit about data, but then also present cases with clinical challenges that we have every day when we try to take care of patients. The title of this webinar is Managing Bleeding and Ischemic Risk in Complex Patients. Do we have the evidence to guide decision making? And I'm joined by two great colleagues. The first is Elvin Kedhi, who's a professor and interventionalist in the Netherlands and in Belgium. And then also Darren, Mylotte, who's an interventionalist and a great operator from Galway. And so this is truly transcontinental, and we'll have some good discussions. I'll start with a brief amount of data, but then move quickly to the cases so we can really talk about what everyday practicing interventionalists have to deal with. So just to start, we'll talk a little bit about what the evidence is to guide decision-making, specifically regarding the Resolute Onyx stent. I think it's important to recognize that the evolution of what we used to think was right in terms of duration of dual antiplatelet therapy has been something that's literally evolved over time. It was clear when we had bare metal stents that we needed to have dual antiplatelet therapy on board to reduce the risk of stent thrombosis. But then there was also atheropreventative benefits to dual antiplatelet therapy. And just this slide, which is kind of a historical slide, shows how we've changed, especially in the drug-eluting stent era, from longer durations of DAP to potentially optimizing DAP with shorter durations, particularly for patients at highest bleeding risk. And in the latest iteration of the guidelines, we can see that there's sort of this characterization of patients who are at normal bleeding risk who can potentially benefit from longer durations of DAP, but then those with higher bleeding risk for whom longer durations of DAP would incur a risk of bleeding, we want to cut back and have shorter durations overall. Now, the bigger question though is even if we can cut back, what is the minimum duration of DAPT after a coronary stent? And the reason I like to sort of ask this question is for the practicing interventionalist, we don't know when a patient's going to bleed. We don't know when patients are going to have adverse outcomes. And even if we identify upfront somebody who's at high bleeding risk, it's important to recognize what that safe duration might be, or a safer duration might be for patients with coronary stents. And the reason that's important is because it's not just relevant to people that are at bleeding risk to start off with, but even for those who might become at high bleeding risk after we have the PCI. And we don't want to be in a situation where we're hamstrung by trying to weigh discontinuation and the benefits of that for bleeding versus the risks of a thrombotic event. And so this has been really emerging as a field of study, and the ARC consortium came together and published this manuscript in both European Heart Journal and Circulation that looked at what the criteria were for high bleeding risk. And they came up with several categories. Some are are stronger risk factors, some are less strong. But overall, if we look at all of these categories, they fit into age, they fit into bleeding history, iatrogenic things, comorbidities, laboratory abnormalities, and the like. And so this is sort of something that you should familiarize yourself with when you see a patient. And you'll actually find that you see these people quite frequently when you take care of them in the cath lab, especially in the current day and age. So what is the data that's out there? And what we tried to do is try to do some randomized trials as well as some observational data analyses to determine if we could identify if a month of dual antiplatelet therapy would be okay with the Resolute Onyx stent. The reason for that is that a month was something that was thought to be too much. You really needed to go 3 months, 6 months, even beyond that. But with emerging data, specifically with tailored stents that are more biocompatible due to the polymer, stents that are thinner strutted, perhaps we could reduce this to just a month. And so what the Onyx 1 randomized trial did, it was a randomized trial to assess the efficacy and safety of Resolute Onyx treated with 1 month of DAP versus the BioFreedom drug-coated stent treated with 1 month of DAPT. And the reason BioFreedom was chosen as a comparator is because in the Leaders Free trial, it was shown to be similar in terms of actually better than a bare metal stent when used for this indication with a month of DAPT. In terms of the performance of that stent, there were some challenges with it, and the idea here in this particular trial was to compare a contemporary DES with the BioFreedom stent to basically see if the results could be matched and perhaps even better. The primary safety endpoint was a composite of cardiac death, MI, or stent thrombosis at 1 year, and then efficacy was also assessed in terms of not only repeat revascularization endpoints, but also angiographic efficacy too. Now, one of the interesting facets of this study that differentiates it is the fact that because biofreedom was approved in Europe and used for these high bleeding risk patients, in a randomized design, you can basically include everybody pretty much who comes to the cath lab. And so these patients were elderly with a mean age of 74. The incidence of diabetes was almost 40%. And then in addition, the rates of acute coronary syndromes were 50%. And that is a little bit different. For some of the US approval studies, we've had to restrict enrollment criteria because the FDA deemed it potentially dangerous to treat higher risk patients with just a month of DAPT. But because this was the practice in Europe and could be done with the biofreedom stent, it was allowed within this trial. And that's why you see 6% of patients with STEMI in the Resolute Onyx arm of the clinical trial. The HBI criteria are shown here. Most patients were elderly, but oral anticoagulation represented up to 40% of the patient population, and all of the other criteria are shown here. It's also important to recognize that patients are patients. They're not just sort of case report forms that an investigator fills out. And that's why the mean number of HBR criteria per patient were 1.6. So 46% of patients met 2 or more HBR criteria when they were enrolled in the trial. Here are the primary results, basically showing no differences between the 2 stent types with respect to the primary endpoint, the incidence of myocardial infarction or cardiac death. Stent thrombosis seemed to perhaps numerically favor the Resolute Onyx stent, but this did not achieve statistical significance. A lot has been made of the rate of events, particularly myocardial infarction that was seen in this clinical trial. I just want to emphasize that this was because in the trial, if you look where these events occurred, they all occur at the day 0 point, if you look at the slide in the top right. The reason for that is that cardiac enzymes were assessed in every single patient assiduously, and enzyme elevations were adjudicated according to the universal definition of myocardial infarction, which essentially calls a lot of periprocedural MIs that may or may not have clinical sequelae or significance notable. And the reason I can say that is because if you look at the cardiac death rates, they're quite low, and in juxtaposition to the MI, this is because these events likely don't cause periprocedural or late long-term sequelae. Now, if we look at the landmark data from this study, if you can advance to the next slide, please, what you will see is that the majority of events occurred within the first month. And then beyond the first month, this is when DAPT was discontinued. You can see that there's a steady accrual of events, but these event rates are lower. And between month 1 and month 12, this does, at least in terms of myocardial infarction, favor the Onyx stent, but this is a post hoc analysis, so we shouldn't get too excited about that as a whole. I will comment, though, that in terms of angiographic success, the Onyx stent, because it's a more deliverable stent, was used more effectively within the trial than the biofreedom stent. That doesn't apply to every single case, but particularly for the tougher cases, because of its stent characteristics, that was something that was observed within this randomized comparison as well. Next slide. So what we then did is we extended the results of the Onyx 1 randomized trial and enrolled patients in the US predominantly, but also some in Japan, an additional 700 patients. And in combining the results of the Onyx patients in the US and Japan with those in the randomized trial, we have an evaluable sample subset of 1,506 patients. And then we did a comparison to historical controls to determine whether that would be acceptable and safe for patients in whom DAPT was discontinued at a month. Next slide, please. And in this analysis, what we showed was the overall rates of stent thrombosis were low, overall rates of myocardial infarction were acceptable. Now, they don't look low, but that's because many of these high bleeding risk patients, and we'll see this in the cases that we're going to show in a second, are actually complex cases. And so these patients do have cardiac events, but compared to what we would have expected, this was well within the performance goal that was set within the trial. And so therefore the trial, this study met its primary endpoint. Next slide, please. So in conclusion, we have a few things. And one, it's important to stress limitations. So the studies are powered for non-inferiority. They cannot be determined to be definitive that it is safer to stop at 1 month versus a longer period of time. But the question clinically that gets asked is, what is going to happen if I stop at a month, if I have to stop at 1 month because I have a higher risk bleeding patient? And in so that regard, these studies can be very informative. I will mention, as I mentioned before, that periprocedural MI was ascertained very assiduously with biomarkers, and that's probably not something most clinicians are doing in practice. Certainly in our lab, we do not routinely assess biomarkers because we know from a lot of streams of data that they don't necessarily impact clinical outcomes. And that contributes to some of the endpoints, which is why we present the landmark analyses, which is from 1 month to 12 months after dual antiplatelet therapy is stopped. Just let me see if I can advance it. And so in conclusion, this is a contemporary DES versus drug-coated stent trial investigating 1 month of DAPT in a complex high bleeding risk population. Complex lesions were included, STEMIs were included. It was 50% ACS, almost 40% diabetic. And in this population, treatment with the Resolute Onyx stent with just a month of dual antiplatelet therapy was as safe and effective as BioFreedom stent. The Onyx stent had improved angiographic outcomes and device success, probably because of its stent characteristics, and further extension to the US population in the Onyx 1 Clear analysis, which was presented at the ACC, also demonstrated similar results. I think on the basis of these data, this is why in Europe, this stent is CE marked for 1 month of DAPT in high bleeding risk patients. And with that in mind, I've sort of wanted to summarize the data relatively quickly, and now we'll go to cases where we can discuss not only the intricacies of the individual cases, but also stent selection, patient selection, because as interventionalists, we want to be doctors, not just technicians, and these issues of high bleeding risk really affect how we take care of patients on a daily basis. So with that, I'm going to conclude, and maybe we'll move on to the first case that Elvin Kedhi is going to be presenting.
Thank you, Ajay. It was a very nice setup, and I would like to show you a case which is a typical case of a high bleeding risk patient, and as is most of the times the case, and we have learned that these patients are not only high risk of bleeding, but they are also complex PCI patients, that these things go go hand in hand by each other, and we see that more and more that these patients are also difficult to treat. So if I can have my slides, I would like to show you a typical case of these patients. Okay, the patient that I would want to present was a male of 92 years old, but in very good general condition, good mental health. The only clinical history he had is hypercholesterolemia, hypertension, and episodes of paroxysmal atrial fibrillation. Therefore, he was in oral anticoagulation. The patient presented with an acute coronary syndrome on another hospital, was there first observed and was presented to us on a very late Friday afternoon. Can I have the next slide, please? As you could see, if I look to this patient, he has not only the age, he was 92 years old, but he was also treated with oral anticoagulation and doxaban. And we performed this angiography, and as you could see, the lesion was a very severely stenosed, dominant right coronary artery. As you could see, that lesion is also very calcified, where there were no other lesions in the rest of the coronary system. So we decided to, the patient was quite stable at the moment. He has no chest pain anymore. Of course, he had a timid free flow. However, considering the severity of this lesion, we decided to perform a PCI on that. And the PCI was performed first with, we tried with a simple balloon upscaling and trying to, because it was quite ostial and not very diffuse and severe, we tried to treat that on a classic way, also because frankly, it was a very late Friday afternoon, and because of the age of the patient, we wanted to take things quite simple. But as you could see, the lesion was so severe, the balloons were always moving out of the stenosed lesion. And then again, we did upscale of the balloon size in different sizes. And we had a couple of balloons who cracked. And then after we tried, as you could see in the image on the left side, with a very with a 3.5 balloon, you could see that there in the middle of it, it could not expand. So it would be an error at that point to place a stent on this patient. This was the TIMI flow we had at the moment. So we decided to, considering that he was quite stable, to observe him over the weekend. He had TIMI 3 flow, and then take him back on Monday morning and perform rotoblator onto this patient. So that was also the case. We start the procedure here with the rotoblator, and I did not place a pacemaker, a temporary pacemaker, but we were ready to perform pacing through the rotoblator wire and through the groin of through the arm of the patient, if that would have been necessary. So as you could see, we started the
rotoblator. Elvin, if you don't mind, if I can just interrupt real quick, because I think it's good to have a discussion of
yes.
this. So, you have a case, and the case is, a lesion that is more complex than the typical lesion that's being picked. So, Darren, what would your approach to this be? Is rotoblator sort of your first option? And the second thing is, let's talk a little bit about this pacing issue that we would use with roto. Is that something you normally do? And if you do you do it with a separate pacer, or do you do it via the wire? And how do you do that setup?
Well, what we do here, we've tried it a couple of times. First of all, if you know how to perform rotoblator well, you could see that if you don't do very long, you don't use the bore for a very long time, you could see that this helps to not have rhythm problems. But anyway, for a dominant ride like this, normally I would put a temporary pacemaker. Now, to not have the groin punched by this patient, we have learned that you could do pacing by putting the two anode and cathode of the pacemaker, one on the arm with putting a little needle on the arm, and the second you could do through you can connect it through the wire where the rotoblator wire, in this case, or the PCI wire. But you need to be careful if you do that. You need to put a balloon over the wire, because then you lose a lot of energy if you leave the wire unprotected. If you need a pacemaker, then you need to put a balloon over the wire balloon, or a balloon to the wire, and then you can perfectly pace for some time, and eventually you can place a pacemaker if you need it. But through the procedure, this is pretty easy to do.
So if you need it, you basically take the rotobur out and then you put the balloon over so you don't lose the energy and pace.
Yeah, sure. But if you have the rotoblator, it's actually is the same effect. You don't need to take it out.
Right. Okay.
Yeah,
and Darren,
and obviously, unlike TAVI, we know that that any conduction defects with rotoblator tend to be very short-lived. So this is a good solution rather than placing a temporary wire in a 90-year-old through the groin. That's probably excessive.
Yeah, I think other options too is you can place a pacemaker via the brachial vein as well. There are sort of ones that you can do that way. It's just a little bit harder to float. And it's interesting, at many conferences you hear people talk about they never use pacers for rotoblator. And then you sort of say, well, that I understand that you never use it, but what about those times when you get heart block? And well, in those cases I use pacer. So that doesn't mean you never use it. You do have to use it sometimes.
You need to be prepared.
Yeah, and I think being prepared, especially given the demographics, is important. The only other thing that you could sometimes do is use aminophylline, and some people do that prophylactically as a pharmacologic agent, and that can certainly help. Okay.
Also the reason why I didn't want to put a pacemaker onto this patient is that sometimes by doing TAVI, we have learned that pacemakers, although they are quite traumatic, sometimes they can cause a perforation. And we did not stop anticoagulants on this patient. So this is a safer way to do it.
That's right. And I actually think that the one thing that also should be mentioned is the staging of this, how you there were issues early on, and before you beat up the artery too much and make the patient unstable, to bring the patient back for a dedicated attempt is a judicious approach. Too often interventionalists don't know when to stop, and this was a good example of knowing when to stop and then coming back.
Ajay, I think you asked a good question about so you've had some difficulty with the first procedure. How do you plan the second one? And I think as Elvin has stated, you need to be prepared to change tack in this. So Elvin, I'm interested to see, but I think probably upfront intravascular imaging to try and understand the calcium burden, the location of the calcium, the distribution of the calcium, and then obviously choose your weapon, whether you decide to go with rotoblator, intravascular lithotripsy, or even cutting balloons. So looking forward to see how you deal with this lesion.
Exactly. I wanted to use actually intravascular imaging, in this case OCT, although it was an osteal lesion, but if you do it right, it works perfectly too, as I'll show you later. It was so tight, this lesion, so I didn't start up front. It was quite clear from what I saw from the balloons and how the rotoblader was behaving. I hope the slides will start moving again. Yeah. So actually, quite unexpected for such a short lesion, I needed 6 attempts of rotoblader of 20, 30 seconds average to go through it. And you could see in the slide completely in the right is where the rotoblader starts going through. And even then, it's not that easy. I had a 1.5 burr, and that's my usual approach. What I also do, and this may be also a point of discussion, is that most of the times when we have lesions, vessels that are up to 3, 3.5, and you go with a 1.5 rotoblader, you can crack all the calcium. And however, what I also do when I do rotoblader is that, as you see on the right slide, I go over it. Even I have crossed, I go over it sometimes with a lower RPM, because this creates a sort of resonance. That's at least how I was learned. And sometimes I've seen it on intravascular imaging that it also causes cracks by just moving up and down with the rotoblader. Even you have crossed the lesion different times, it creates cracks on the calcium, and it allows it further to be easily dilated. So after I did this, I performed indeed a OCT to see what I was dealing here with. And I also use the image of the OCT to not use too much contrast to see also what the result is of my rotoblader. And as you could see, there was an improvement of the flow, but still a severe lesion proximally. There were no apparent dissections. And here I'll show you a very nice image. It's like the effect of the rotoblader. You could see the very calcified lesion, and you could see the tunnel that the rotoblader created on that. And strange enough, there is only one big lesion or dissection, let's say at 6 o'clock going down. But for the rest of it, this lesion is completely uncracked. And you could see still 1 centimeter of calcium on top or almost around it. So this is still severely calcified. However, I said I'll try to do it on the classical way now, use some non-culprit balloons at high atmospheres to crack it, and that's what I'm doing. I hope you could see here the first balloon. These are not films. It's like I recorded the moment that I was working. So you could see the balloon goes in, will be inflated soon. And at a certain moment, while I go up on atmospheres, it will crack.
Now, Elvin, this point of going up with an NC balloon after atherectomy is such an important one, and I still see operators who don't do it. The challenge here is that many people feel that if the reason to do the atherectomy is to be able to get the stent through. And especially with the newest stents that we have, they deliver much better than the older stents.
Yes.
But the issue is it's not just delivering the stent, it's expanding the stent, and that's what ultimately determines the outcome.
Exactly, that's why you need to use a balloon.
It's worse to get the stent there and not expand it than it is to not get the stent there in the first place.
Then you start a bigger problem.
Yeah, so what you did with the NC balloon is really important.
You see if it's expandable, and then you see if you need to upscale either the rota size or use other atherectomy devices. So I'll try to move to the next slide. I also used another balloon again, a bit larger this time, and I also performed as they used to call it before hammering. So when you're up to 20 atmospheres and you go 23, 20, 24 in a repetitive way to create a bit of oscillance on the lesion, but also this balloon, as you see, will crack again. So at this point, and looking to the OCT images I had, I understood that I had to do something else. So I could, because there is still about 1 centimeter of calcium there, I could use another bore or use shockwave. And I decided in this way to use shockwave mainly because the circumferential calcium is short and it's a thick layer of calcium. And shockwave is very good to be used in these cases. So you could see here On the right side again, I'm bringing the shockwave in. Unfortunately, the balloon was not well prepared, so you could not see it very well. And I did the first 10 runs because you need to go 10 times with the shockwave. And that works well, but I decided to repeat it once more, and that's the next slide. And actually the next slide, if it works, yeah, oops, sorry. So, yeah, actually this is a film from the screen, because I made it to see what happens with the electrocardiogram. You could see the spikes that are generated from the shockwave. So you know this is a shockwave procedure. And as you could see on the OCT imaging I did after that, you could see that where I have this very clearly round tunnel, now there are cracks shown of the white arrows created. These cracks are about 1/2 centimeter thick. And I showed you only this slide, but over the whole extension, there were the same typical cracks, sometimes thinner and sometimes deeper. So after that,
Elvin, even looking at the OCT long axis, you can see that the opening is much wider at this stage.
yes, it is.
As well as those fractures. It looks like you've done exactly what you needed to do to prepare the landing zone for the stent here.
And actually what is interesting is that where we had this very clear tunnel that we saw before with rotablator, right there on the top, you could see between 12 and 9 o'clock, they are very nicely, these are the typical cracks you see after OCT, on OCT after using shock waves. These are regular and like, yeah, that's the typical appearance of it. So after that, I performed, because now we are in the situation, we crack the lesion, balloons extend, because I saw the shockwave balloon extending, opening quite well. And we are in the situation, we're gonna perform an osteal stenting. And I use here a special technique to do the osteal stenting, especially when there is very calcified and you don't see the ostium very well. And sometimes, depending on the orientation of how the ostium of it is oriented, you could miss the ostium a little bit. So there is a nice technique to do, and I've used these techniques quite a lot. And what you do here is then, this is a situation, I hope to advance the slides. So this is a situation, you put the guiding, you have the wire that goes into the vessel, then you have a wire that goes outside. Over that wire, you put a semi-deflated 1.5 balloon with a mid marker, and then you press the guiding so that it makes this typical bend, so you know you are at the ostium. And then all you have to do is retract your stent, the proximal marker of your stent to the proximal marker of this balloon, and then you know you're absolutely right. And what it does also, it avoids what it's called this swinging of the catheter and the stent with every heartbeat, especially in large vessels. And it allows you to know exactly when your ostium is. Because this balloon we're using outside the ostium is 1.5 millimeter, then bringing the stent to the mid marker of it makes that the stent is about 0.5 millimeter, 0.5, at about 7 millimeters outside. So that's exactly how you want it to have. And then after you do this, you just inflate the stent and you know that this is going to be okay. It avoids all this shifting, and it makes that the stent, all moves in synchrony. The guiding, the ostium and the stent all are at once. So you can very nicely position. And you can still inject if you have a 7 French guiding. But it's also possible with 6 French. So then I choose this 4.5 18 onyx. And then I implanted it, but unfortunately I did not save this angiography as I did before with the other balloons. And the result was, I'll show you now in a second.
It's actually, it's an interesting technique. I personally have not used it, but it makes some sense. The other thing I just want to make sure people know is that it's really important to know the differences between the individual stents themselves. And so the Onyx stent is a stent that's, first of all, has rounded edges, and that perhaps leads you to get in or deliver a little bit better without getting caught up on stuff. But also the juxtaposition of the edge of the stent to the marker of the balloon is offset a little bit. So fellows often will try to line up the marker with exactly where the ostium is. And if you do that, you're going to potentially miss the ostium because you'll be in a little bit. So I think that may be one of the reasons why, Elvin, with this technique with Onyx in particular, if you're lined up to the mid marker of that other balloon, it means you're outside with the marker a little bit, which means you'll nail the ostium. And that differs from stent type. So Xience is directly on it. Onyx and Synergy, for instance, are in a little bit, and so therefore you have to take that into account when deploying the stent.
Oh, very good point, Ajay. That's a very good point. And also, standing, you need to know exactly the difference of your marker from where the real metal part of the stent begins. And there is another thing to be said about Onyx. It's a very good stent to use in this situation because it has a very good radial force, but also is very nicely visible because it has an inner core of another alloy that makes it very visible and very well you can orient yourself very well by using the stent. And then here you could see the final result as again, you could see that the stent very well expanded. I did a post dilatation though with a 5.0 balloon, but not on the distal edge, only on the proximal edge. And you could see here, I'll play it one more.
It looks great.
Here is the result. Oh, yeah. So it completely opens, it comes up to the ostium, and you can see on the next movie is the OCT after stenting. Oh, I'll try to bring it back. So it gives you.
We can certainly see it on the long view. There's sort of uniform expansion throughout. And I think that may be one of the advantages, Elvin, of your technique with shockwave here, because in the initial OCT, you saw the tunnel in the calcium and then the opposite side looked dissected. And you could argue that if you put a stent in there, it would expand against the contralateral wall at what you had at 6 o'clock. But the concentric expansion that you see here is only possible with the technique that you use. So this is
exactly
really nice demonstration of that.
Unfortunately, this movie is not working, but with one OCT run as you're doing the control angiographically, I'll try to run the next movie. Hopefully it'll work now. But you could see also in the longitudinal view, you have a very good apposition, no distal dissections of any kind, and the stent comes exactly where your catheter starts. So it's completely till the ostium of the lesion. So this was, for me, a very good result. And can you advance my slide, please? Okay, so this patient was a high bleeding risk patient, and then we treated this. And the reason why I chose an Onyx stent here also is because recently the Onyx stent has a CE marked, as Ajay already mentioned, for 1 month of dual antiplatelet therapy. Now we had here a very good stent, a stent that was placed quite well. We have no malapposition. We have a good expansion. And the diameter of the stent was 4.5, that will grow to up to 5 millimeters. So the risk of thrombosis here is quite low. There are no other lesions that would mandate eventually longer duration of dual antiplatelet therapy. And we have a patient that has a high risk for bleeding, was taking endoxaban. So on this information at the hand, I choose for this stent because of its nice performance on complex lesions, his visibility, his possibility of use with 1 month of dual antiplatelet therapy. And then I further treated this patient for 1 month with triple therapy, and I'll continue to treat this patient with, actually 1 month after, I saw him after 3 months, and he already stopped aspirin after 1 month, and he's continuing clopidogrel and endoxaban, and he's doing great because he was a very nice gentleman. And sometimes we're thinking, should we or should not treat 92 years old patients, but this guy was really perfect after this treatment, and it was a good decision to treat him.
So let's talk a little bit about this here. Number one is that you know, I think the points you make are, if the clinical indications are based upon the patient, and we shouldn't age discriminate. If he's an active and healthy 92-year-old, he shouldn't have to have issues and just deal with them because he's 92. So the fact that you treated the patient and did it in a complex fashion, but yet safely, is really important. In terms of the triple therapy, maybe Darren, is this something that you're typically doing, or would you potentially drop the aspirin and just use the NOAC plus clopidogrel? And does the stent safety figure into that as well?
Yeah, I think we're mounting evidence that dropping aspirin may be a safe strategy in the presence of a NOAC. But I think probably more important is the fact that Elvin's got the perfect result here and proven it before he's decided on his antiplatelet strategy. I think that, you know, having the intravascular imaging of a good result gives you the confidence to curtail your DAPT. And what we've tended to do is to give a week of triple therapy and then drop the aspirin after the first week, because most events tend to be in that first week, and then switch to 6 months of dual therapy with a NOAC and Plavix, and ultimately dropping the Plavix after that.
I fully agree. I fully agree. And sometimes if this would have been a non-acute coronary syndrome, which was the case here, I would have been very uneasy on doing the same way. But because of an acute coronary syndrome, also for legal issues, we could not treat patients that way, because we have responsibility and the guidelines mandate triple therapy for at least 1 month. And this has been reduced quite a lot. So at this case, because of acute coronary syndrome, I did 1 month, but actually other ways, it could have been a perfect solution to just go on after a week with a dual antiplatelet therapy, or do anticoagulant and one P2Y12 in this case.
And Elvin, actually, I asked the question more to be provocative, because I don't think that people necessarily recognize that in the studies that were done with NOACs and dropping aspirin, that the average patient in those studies were actually on aspirin, not just through discharge, but for approximately, a week. And that's not well recognized. People just think that they dropped it immediately or they never got aspirin. That's actually not true. That's the first thing. The second thing is that, remember, there is clopidogrel resistance too. And so if you're using clopidogrel and you drop the aspirin, but yet you're resistant to clopidogrel, then you've basically dropped aspirin and everything else, and the only thing you're on is the NOAC. There are meta-analyses that show that there's actually an increased rate of stent thrombosis if you combine all these studies together. Admittedly less bleeding, but more stent thrombosis if you just drop the aspirin. And so I think that's why it's important to consider this aspirin issue. And the points Darren made are so right on. If you get the best stent result you possibly could, then you at least take that part out of the equation, and then you can deal with the pharmacotherapy as you need to.
Excellent point, Ajay, because we know we know that from OCT studies that after a month, at least with Onyx, about 97% of it will be covered. In this case, this will be the case in this patient because we had a very good apposition. So I feel confident after a month whatsoever, if necessarily even to go on with an anticoagulant only and one of aspirin or P2Y12. But considering the clopidogrel could give some resistance, having some aspirin on board, at least for a couple of weeks or 2-3 weeks, will be good. It's very logical to have.
And Elvin, that's really the final piece of the puzzle, right? Of course, we understand that in these patients, for example, the Onyx 1 study where 50% of patients were ACS, that 1 month of dual antiplatelet therapy seemed to do pretty well. What we don't know is whether, well, 3 months of antiplatelet therapy or 6 months of antiplatelet therapy may have tilted that balance between bleeding and ischemic risk in favor of one or the other. So I think we've got a little bit more work to do before we know exactly in which patients we can tailor the therapy and at what point.
That's a fantastic summary statement, and I want to emphasize that because I tried to make that point in the data talk, but this is not to say that we know for sure 1 month is the best approach. That has to be individualized to the patient. But what we know is that if you do happen to do 1 month in patients that were selected to be in these studies, that that was associated with tolerable outcomes and reasonable outcomes, so it gives us flexibility. So with that, let's move on to the second case. Darren's going to present a case, and we'll have similar discussions about it If there are any questions from the audience, you want to type them in, we can then answer them and address them as we go along as well. But with that, let's go to Darren.
Okay, so if we could get the second slide set up. So here's a second case, and while Elvin gave us a case of a gentleman at one age spectrum, I'm going to give you a different one. So this is a 57-year-old female, really with an extensive cardiac and non-cardiac history. She was born with bicuspid aortic valve and underwent a 19mm perimount magma insertion in 2005. That turned out to be a very difficult operation with a lot of bleeding, and that relates to her bleeding risk. I'll tell you about it in a moment. She also has prior PCI to her circumflex, ramus intermedius, LAD, and right coronary arteries, and had an ischemic cardiomyopathy with an ejection fraction of 35%. Her medical history is pretty long and checkered, and you can see that she had Hodgkin's lymphoma and extensive wide beam chest radiotherapy many years ago. She's been left adrenally insufficient. She had a splenectomy. She's got Hayley's syndrome, hypothyroid, and a bunch of other things that really make her management quite complex. On this occasion, she presents with two particular symptoms. The first is chest pains, and those were typical of angina. And she had some progressive dyspnea over the previous 2 to 3 months, NYHA class 3 by the time she makes it into the hospital. The physical exam, the most important and relevant, I think, is that her weight is only 42 kilograms, so she's a tiny lady. ECG suggests some anterior T-wave inversion, and her risk assessment in terms of whether we need to do anything with her valve, her STS score is 7.9%, so high risk for operative intervention. The elevated troponin, along with the chest pains and anterior T-wave inversion, suggest that her presentation on this occasion is a non-STEMI. But importantly, as part of her HBR, or high bleeding risk assessment, her hemoglobin is 10.2, her platelets are normal, but her GFR is mildly reduced at 43. So we routinely use the HBR ARC app to try and understand patients' bleeding risk. And this patient had 2 major and 1 minor criteria by the time she came in. We also use this ARC bleeding cath lab checklist for all of our patients, so that before a patient comes into the lab and you're trying to make a decision what stent to put in, that you have the appropriate information for stent choice and DAP choice prior to the patient entering the cath lab. And so in this patient, her diagnosis was, of course, a non-STEMI. She was at high bleeding risk. And our management plan was initially to put her in the CCU to bring her to the cath lab for an angiography and probably a PCI. We treated her with aspirin and clopidogrel, given her anemia with a concomitant PPI, and of course planning an echocardiogram to have a look at her heart valve. She went on to have an echocardiogram, which was limited due to her previous chest wall radiotherapy, and ultimately had a transesophageal echocardiogram. And what you see in this image is a very degenerative surgical bioprosthesis. The gradient across the aortic valve was 41, and the valve area is 0.7 centimeters squared, or an EOA of 0.7 centimeters squared. So all of a sudden, this lady had concomitant severe aortic stenosis due to a degeneration of her aortic bioprosthesis, and indeed her non-STEMI. So she finally got to the cath lab and had her angiogram, and what you see is she has prior stenting at the ostium of her circumflex that looks pretty good. She's got a mal-deployed or underexpanded stent at the ostium of her ramus intermedius with some in-stent restenosis. And in the areocaudal view on the left-hand side of the screen, she has an ostial LAD lesion that's more difficult to appreciate in the areocranial. We performed an FFR on the ostium of the LAD. It was 0.71, and an FFR on the right coronary, which I suppose demonstrates some diffuse in-stent restenosis in the proximal portion, and diffuse atheromatous plaque throughout was somewhat surprisingly not significant. So a significant ostial LAD lesion and some in-stent restenosis in that ramus intermedius stent. She then underwent evaluation for potential valve-in-valve. This was the internal dimensions of her surgical bioprosthesis. I mentioned that was a 19mm device with an internal diameter or 21 millimeter, or 19 millimeter device with an internal diameter of 17 millimeters. She was evaluated for the risk of coronary obstruction, which was relatively small because her VTC, or the distance between the virtual transcatheter heart valve and the ostium of the left main, was 5.2 millimeters, greater than that 4 millimeter threshold, even though she had a low left main of 8.2 millimeters. And so as part of her, her treatment algorithm, we had a heart team discussion about this lady. Oh, I'm ruining it. We can go back. And so we had a lady who had bioprosthesis failure, a non-STEMI with requiring an intervention to the ostium of her LAD. And really the surgeons felt that she wasn't a candidate for operative intervention given her prior radiotherapy. In fact, they were initially a little bit more bullish in terms of her operative risk until they pulled out her operation notes and found that she bled quite considerably the last time that she had her AVR, and indeed they were not keen to take her back. And as such, our strategy was therefore an upfront PCI, so stenting from the left main into the LAD, of course IVUS or OCT guided, and a drug-eluting balloon to the ramus intermedius in stent restenosis, and then get on with a transfemoral TAVI. I'll stop maybe after the next slide, Ajay and Elvin, and ask you your opinions, because 2 days after she had started her DAPT, she had an acute GI bleed with her hemoglobin dropping from 10.2 to 4.9, and following upper and lower GI scopes with no clear source identified. They believed that her bleeding was due to her Hades syndrome in the context of her prior aortic stenosis. And they were very keen that she not be given dual antiplatelet therapy. So what in your institutions, how would you manage this patient, or where would you go from here?
Oh, look, this is real world. This happens. And just a quick question. So the patient had already had the LAD stent or was about to get the LAD stent?
So she had a prior mid-LAD stent. Okay. So we had not intervened on the ostium of her LAD, as was our initial plan.
Got it. Okay. So that's fortunate, because oftentimes this can happen after you've intervened as well, more freshly, and then this becomes a much bigger challenge to deal with. And this shows you this patient is at high bleeding risk just by demographics alone, but now with an additional bleeding event, the risk goes up even further. The question though is that because there's no source identified, if the AS is successfully treated, do you then potentially reduce the risk of subsequent bleeding? And I haven't seen prospective evidence of that, studied in a systematic way, but we do invoke this not infrequently in these types of patients as a way of potentially managing them. But if the surgeons feel that she's not a candidate for the OR, then at some point you have to treat the patient, and the question is what the next best way is. Elvin, what are your thoughts on this?
Well, it's for me, it's this remains tricky, because having such a large drop on hemoglobin and not seeing the source, this is quite a large amount of blood you're losing there. So if this happens over 2 days, this is about 2 liters of blood. So this is very difficult to explain that you did not have a source. So this scares me actually. And but this happens, and these are sometimes things we are set up front. So at this situation, you have actually a patient that has a major tendency to low hemoglobin, either through bleeding or other mechanisms. We are not sure about this at this stage, but you have a valve problem, and you have a situation where you have to treat a patient because comes with an acute coronary syndrome, so needs treatment. And you could, the first thing you do, of course, here is transfuse the patient and first get her at a stable level of hemoglobin. And then I would then take the risk to at least treat this patient with treat the acute coronary syndrome and subsequently the valve eventually, and maintain this patient in hospital. Might she need transfusions for the next 2-3 weeks, and then after that you hopefully could drop off the dual antiplatelet therapy. But you are at a high risk patient in all senses here, for the valve, for the lesion you have to treat, and medically seen for the risk of having a low hemoglobin or having anemia. So these are patients with high mortality. this is a very difficult case, and I clearly think that you have to bring this patient back to the heart team and take some decisions at that point. So I think it's what you did. That's what we would have done at that moment. But this is a multidisciplinary patient.
The one good thing, though, that you did, Darren, is I like to call this the bleeding stress test. And that is that in anticipation of the PCI, you give dual antiplatelet therapy. And it's far better to have bled before you do the PCI than after. So you've sort of, in a sense, done a bleeding stress test to quantify risk in a sense. So tell us what you did.
So she failed that bleeding stress test terribly, as you can see. So if we can get the slides back. So we did exactly what Elvin suggested. I think it's important with these complex cases to be honest with the patient, to be honest with their family, and let them know that they are high risk, and that we don't always have the right solutions for them. So we brought her back to the heart team, and the heart team changed the treatment plan given this new event. And the idea was to perform TAVI and to then reassess the patient in due course and to see how she did post TAVI. So at this point, we had stopped both her aspirin and her Plavix. We performed her TAVI without any antiplatelet therapy and, of course, without an anticoagulant. She had suitable transfemoral anatomy for implantation of a 23 millimeter Evolute R. The coronary arteries were protected, even though the VTC was relatively wide at over 5.
Can I stop you here and ask you a question?
Sure, please.
I see you have a wire in the LAD, so you're protecting. It's like the chimney technique.
Yeah. So Elvin, our assessment prior to TAVI suggested that
yeah.
her risk of coronary occlusion was moderate at best. But in this young patient, if there's even moderate risk, we'll just leave a wire down the.
No, on CT it was a high risk. You could see that.
Yeah. And
particularly with this valve,
you can see there's a wire and a balloon left in the LAD.
Yeah.
If we were really concerned, we probably would have left a stent rather than a balloon. But we were pretty confident that we wouldn't have to deploy the balloon. So this was our setup. We went ahead and opened the valve, checking, of course, the left main as we went along. And post implantation of the valve, we unfortunately had this very considerable gradient of nearly 40 millimeters of mercury. And so the next step, and again, this was one that we had assumed would happen, was to fracture that surgical bioprosthesis with a 20 millimeter true balloon. This gave us a great hemodynamic result with a final gradient of 4 millimeters of mercury.
Those are great tracings. That's fantastic.
Thank you.
I'll
pass on the good news to my cardiac tech. And as typical with a valve in valve, you don't get any AR if you put the valve in the right place, and you can see a wide open left main ostium at this point. So a couple of days after this, the patient had no further bleeding. Her hemoglobin was stable, and so we felt it was time to go home. We put her on a single antiplatelet agent, which was Plavix rather than aspirin, and we followed her up in the outpatients. And initially, she did pretty well. She certainly had no further bleeding episodes. But like most things in life, they don't always stay good. And she came back to us a month later with a low level troponin and some chest pains. And of course, we were then left with the decision to fix the left main into the LAD again, and this time through the struts of her transcatheter heart valve. I will say at this point, her hemoglobin was stable at 10.2, which was her pre-GI bleed level when she initially came to us. We gave her that stress test again. She had 2 days of dual antiplatelet therapy and did not bleed on this occasion. So Ajay, you suggested maybe treating the aortic stenosis can take the initial pressure off those duodenal and GI bleeders. So maybe that stabilized her. And so we got on with her PCI through the struts of the core valve. You can see initially that this is a JL35 catheter, which is a little bit too short. It leaves us a little bit too high. If I can advance these slides, sorry. You can see we're just a little bit too high on the valve frame. So we went with a Judkins 4. We came out through the struts using the 035 wire, and then we were able to wire from a distance down the LAD. And really from that point, the PCI was relatively straightforward. We did an upfront IVUS, balloon dilatation, a re-IVUS to ensure we had appropriate expansion. We stented from the previously placed LAD stent to the ostium of the left main, pot a kiss between the ramus intermedius and the circumflex, a kiss between the LAD and the ramus intermedius, a final pot and a final IVUS to ensure that the result was optimal. If I can
Yeah, and just one quick comment. That's a phenomenal result. But again, also look at the way the technique was done. This is a high-risk patient. She's already had bleeding issues. You've done the re-bleeding stress test, a repeat bleeding stress test, and she's successful. But she could potentially bleed at any time. And so the result that you get has to be perfect. And that's why the imaging is used. That's why all the pots are done, the kisses. And it's also not always easy to get in through the frame of the prosthesis. So really got to make your best effort. And that's why this HBR population marries the advances in PCI technically with the pharmacologic decision-making over time that changes. And it's sort of these are thinking cases. You have to think about them and then do them with a high degree of skill, which you've done.
Yeah, and I think that's true. I think leaving a patient like this with 1 month of DAPT with a first generation drug-eluting stent or a bare metal stent, in an F main, that's not something that we would have done 5-10 years ago without the understanding that we had done this as well as we possibly could. So we had a good acute result. She went off home with a strategy of dual antiplatelet therapy for 1 month, and at 3 months she came back to us. Unfortunately, again with some chest pains, but thankfully her cardiac troponin was negative. She did have a relook coronary angiography, and that was stable with no deterioration in the acute result. She's been discharged home and to date has not rebled and has not had any ischemic events on aspirin monotherapy.
Well, that was a fantastic case, Darren. And I want to stress one thing here. It was a difficult case. And as you correctly said, some years before we had these tools and this experience and these kind of stents and this evidence that we could treat these patients with short dual antiplatelet therapy, we similarly as the surgeons would have also rejected this kind of patients. And luckily now we can, and these are great advances. These people are really helped in this way. And that's thanks to this kind of research that shows that sometimes even these complex patients with shorter durations of dual antiplatelet therapy can be helped. Very good case.
And actually, talking about what both of you mentioned is that, just until recent advances in stent technology, this would have been, virtually impossible. You'd be doing with a bare metal stent and, you'd still worry about the dual antiplatelet therapy. And now, because of the advances in technology as well as the generation of the evidence that suggests that you can treat these types of patients with shorter durations of DAPT, it allows us to be able to take care of these people more effectively. We all know that if in an ideal world, surgery would have been great for this patient, but the patient can't have surgery. So this is why we do what we do, and now we have tools to be able to do them. One other point to mention technically is you didn't need it for this case, but especially going through these frames can be challenging. You showed a little bit about how to get the guide through, but guideliners or techniques like that with a telescope, for instance, which is something we use pretty routinely in our practice, can be really, really effective at being able to do these cases 6 French through calcium, through prostheses of valves, and to be quite comfortable doing them. Darren, anything else technically about that case or otherwise? I really like how step by step the plan potentially iterated as the patient needed, and you ultimately treated her successfully.
Yeah, that's real life, right? You have to react to the patient in front of you, and the evidence doesn't necessarily help you with that. So as you mentioned at the outset, we're clinicians and we have to take care of patients. No, I think, I mean, the only other thing that we were cognizant of when implanting the heart valve was that we had to try and line up the commissures of her aortic bioprosthesis with the commissures of the core valve, and we're able to do that through some work with Gilbert Tang and some other colleagues in terms of how to line up an evolute prosthesis in an anatomically appropriate position so that we can get through those struts. That was an interesting facet of her management, but no, otherwise I think the usual toolbox, but making sure that the acute result is as good as it can possibly be, I think is just crucial in these cases.
Yeah, and actually picking up on that, Elvin, I'll ask you a quick question that came from the audience. You know, how important is the imaging optimization to reducing antiplatelet duration? What do you think, Elvin?
Is for me the question, yes?
Yeah, yeah.
All right, okay. No, I think in this case it's very important because we could have very good stents, but you need to have also very good results. In this case, the imaging will help you, as it helped Darren, correctly doing it before and after. Before, because it helps you looking to the exact strategy and how to approach the lesion and what material to choose, and afterwards to make sure you don't leave after things that you would regret or that leave the lesion or that have a perfect procedure. And in this case, and I want to also add something on what you said before, using sometimes guideliners or Godzillas or all these telescope systems helps you to perform and do a great job and reduce the contrast and also improve the imaging afterwards. And in this case, Darren also did an IVUS before and an IVUS after. I did an OCT before and OCT after the case, and gets you a good feeling to see that you leave. Most of the time, these osteal lesions are quite large. We put large stents there. So if you put it right, you could be sure that knowing that after a month, this stents almost covers, then you have a very good feeling to stop dual antiplatelet therapy. And the imaging here is crucial in this kind of cases. If you don't use a lot of contrast, or if it's possible to do it, I certainly would do these kind of cases, left main osteal lesions with imaging, particularly in these patients.
Fully agree. And we talked about that through the course of this program, and that it's not just the pharmacotherapy and the stents, but you have really got to make sure you do the best possible job. Another question that came in from the audience is, does the inflammatory state of the patient, i.e. the acuity of the syndrome, stable patient versus ACS, should that influence the duration of dual antiplatelet therapy? What are your thoughts? Maybe Darren, you can take that one.
Yeah, I think so. Obviously, if you've got an ACS, that's going to tip your balance from just considering the bleeding risk towards considering the ischemic risk. The thrombotic risk we know is much higher in patients who have had an ACS. The other, I suppose, relevance to an inflammatory state is whether that does not just relate to an ACS, but rather comorbid conditions that the patient may have. And of course, inflammatory conditions are more likely to be associated with acute coronary syndromes and thrombosis. But anti-inflammatory medications such as steroids and non-steroidal anti-inflammatories are more likely to be associated with bleeding risk. And certainly they form a minor criteria for the HBR-ARC criteria. So I think understanding the presentation of the patient and understanding very completely their past medical history, I think is key to optimizing the treatment strategy for the patient, if possible, prior to the point at which they get to the cath lab. I showed you at the start, we use that HBR pro forma to screen all patients before they come to the cath lab, to ensure that before we get started, we've got the right stent in our hand, we've got the right antiplatelet therapy, whether we need to ensure that we use imaging, and so forth.
Yeah, and actually, if you look at those criteria, which are all, and this is evidence, so it's based upon risk factors for bleeding, it turns out that this is not like 10% of patients we treat. This is more like, 20 20 to 40% of patients that we treat in the cath lab, and potentially increasing currently. So it's very important to be comprehensive in your assessment. And it's also why there are newer studies looking potentially at, monotherapy or dropping aspirins, or for instance, the Twilight study in these types of patients that are so important, because you can recognize that they may benefit longer because of that heightened state of thrombosis. But on the other hand, that just incurs bleeding if you just do it indiscriminately. So this issue of monotherapy is one that's emerging. And it brings me back also to the imaging, where if you have a very, very good result acutely, then you feel more confident about dropping things late. It's those patients that you meet for the first time in the office and they want to stop their antiplatelet therapy. You got to go look at the films. You have to see how it was done and what was done at that time before you just sort of indiscriminately say, okay, sure, it's fine to drop whatever. Any final comments? Otherwise, I think it's been a fantastic discussion with cases, some data, but real world clinical practice. Elvin, any final thoughts? And maybe I'll pass it to Darren, and then
you just said it before. You just said it before we were thinking that these high bleeding risk patients are just not a lot of patients. But now, and Darren said it also before, we are treating patients that we were not treating before. And these patients are there. And as people are getting older, we're getting more and more calcified lesions. As they're getting older, their morbidity, other risk factors that make them use anticoagulants or have other disease that makes them being at high risk, like cancer or so on. These patients, as they get older, they get high risk of bleeding, and they get also complex patients to treat. So we have to learn that if you want to treat these patients, these older patients and these high risk bleeding patients and these complex patients, this is a large population. And because we are accepting them now, we'll see that there are not so few. We are referring to data we had before, but right now, as you said, these are a quite large population, about 20–30% of our patients, if not more.
And Darren, any final thoughts?
Yeah, maybe a call to arms. We've discussed for many years the individualization of treatment strategies for patients and personalized medicine. And I think that this is one great opportunity to do that. And I would call on interventional cardiologists not to just give everybody a year of DAPT because that's the easy thing to do, but really to look at the patient characteristics, look at the stent characteristics that you're implanting, get a great result, and then individualize your treatment strategy, because it can have a profound effect on the outcome for your patients.
Yeah, I couldn't agree more. And one of the best things about being an interventional cardiologist is that you can do the procedures in the lab, but we can also be non-invasive cardiologists and do the procedure and take care of the patients outside the lab. In fact, that's one of the most fulfilling parts of what we do, is we can take care of the patient from A to Z. And this is just a way that we can do that by focusing on these HBR patients. We have emerging tools that have enabled us to be able to take care of these patients more effectively. And we showed you that through some of the trial data that we presented. We talked about two great cases, both acute coronary syndrome cases that involve complex PCI techniques, techniques that should be familiar to people, so that we can take care of increasing the aging and more complex population, and then ultimately determining how that modifies the pharmacology strategy and how those two are very closely intertwined so as to take care of patients in the best way that we can. So on behalf of all of us, Darren, Elvin, it was fantastic having you here. Thanks to everybody who listened, and for those who will be watching subsequently, and I hope you learned something. I certainly did from this, with some techniques, tips, and ways of thinking to try at home. Take care.